Thank you very much, first of all, for the invitation and for the possibility to reflect on communication from different perspectives. So from the perspective of a person who experiences HIV care in different settings, in different countries, as a migrant person, but also as a person who is trained in linguistics and ardent follower of Noam Chomsky, and then a person who moved to public health and worked on implementation and delivery of services in prevention, testing, and clinical care, and really thinking about the communication and how to make it better. Here are my disclosures, and I would like to start with shared decision making, and I'm really happy that we talked about it already today, about partnerships, what needs to be done, and about co-production of care, because we are doing interdependent work. It's about creating, designing, producing, delivering, assessing, evaluating together, and interactions of patients and professionals and shared work is really crucial. I would like to read this one quote because I really love it. It touches my heart somehow. On an individual level, according to this model, a healthcare service is usually composed of a relationship and an action. When a trusted health professional explores a patient's need and a relationship is formed. This relationship is key to agreement and to shared actions that might follow, such as procedures or drugs. Patient and professional are held together by knowledge, skill, habit, and willingness to be vulnerable. And this is, I think, where communication comes in. And we know that within healthcare, communication is the foundation for obtaining medical history, conveying the information to the client, supporting treatment plan. We also know that good communication skills show to improve satisfaction of care and also adherence to therapies among the patients. And also we know that establishing a trusting relationship with common goals is critical for mutual benefit for the client and for the provider. We also know that there are multiple barriers to appropriate communication, and I think this is not an exhaustive list, and I'm sure you all would be able to add 1, 2, or even more points. But we talked today also about increasing number of patients assigned for provider. Health literacy, it might be a challenge. Time is a challenge. Also, the illness itself and expressing the state of illness by the client might be a challenge. Cultural differences. We were talking about migration, and I will talk about this too, because this is an important factor in care, and language, how we are able to communicate. And I would like to start in communication from the basics. I do believe that it starts all with intention. With intention, where we come to meet a person, and where we also, as a provider, as a person who talks, where we come from. Is our intention, or does our intention come from the heart? Because this is the positive, I do believe that the positive communication needs to come from the heart. Of course, we work within the brain realm, with communication, with information, but then it is about really why we are meeting the client and what we want, how we want to support the person, and if we have time to listen, to actively listen, and to be present. This is what we were talking about today too. And also, I think we need to understand, and we know all this, that emotions are important, and positive emotions like love, gratitude, joy, how we express ourselves, what emotions we use, also influence the communication. And I'm sure many of us know the work done by Dr. Masaru Emoto, looking at how emotions influence the water, and we know that positive emotions can really bring beautiful results in communication, but then as an effect probably into healthcare outcomes. Of course, language matters, and we know that language can empower or can reduce the person. The language shaped person-centered care, and language can be supportive or not so supportive in care. There is a need to use positive words, focusing on positive words with the positive meaning of the words, and also positive sentences, that the person has a feeling of a positive conversation. Person first language, and Laura, thank you once again for your work on this. And I also I was in 2012 also involved with Salamander Trust on working on the paper. So I do believe that this is so important to have this continuation, and I do believe that it's not about HIV care, but what we are doing in HIV care can really support positively the whole healthcare field. Avoiding the language of war. This is again using positive words, and keeping conversation kind and simple with the focus on education. Thinking about the person when the person is. Of course, not always we have an understanding, a deep understanding, but it's about listening again, feeling the person, and understanding in what where the person is through empathy. Also, what I do believe is important is to look when the person is in terms of the cycle of change. And this cycle of change by Prochaska Di Clemente is used mostly in the area of drug use, but not only. It's about the change, motivational interviewing, and being able to understand where the person is with any issue. If the person is in the pre-contemplation state, if the person even has no understanding about the issue, or maybe the person starts to contemplate and think about the change, the person prepares, or maybe is already in the action state, or maintenance. And we need to understand that this cycle is really a cycle. So a person can be in each state and can move forward. So it's really important to have an understanding where the person is. And let's talk about some about some messages. Undetectable equals untransmittable. What we know that only a part of infectious disease specialists and primary health physicians talk about it, and there are certain reasons why the healthcare providers do not report or withhold the information to the people. And this is related to disbelief, despite of the evidence, perceptions that E equals U, negates personal responsibility, concerns about patients' behavior, and misunderstanding. And we also know that there are direct benefits connected with attainment and maintenance of viral suppression, also better motivation to start and adhere to treatments. There are psychological benefits. We are alleviating self-stigma, relieving guilt, and we can think about sex and sexual life without fear. And then also there are indirect benefits, community viral load, and then population level incidence that can be affected by this. And in terms of public information about U equals U, we need to reduce HIV stigma, motivate testing, and lessen anxiety about HIV acquisition. I think here the nurses and pharmacists and everybody, I think we can do much more and think how to get with the message to more general public, but also to other healthcare providers. I would like now to talk a little bit about the migration, because I think looking at different groups, definitely people with experience of migration, and then we have different groups. We have refugees, we have internally displaced people, we have we have seasonal workers who move to one country or the other, or we have students or undocumented migrants. So depending on which group the person is in, the person will have different challenges connected with accessing HIV care and also with communication. And what we know that there are across the field, there are huge gaps related to prevention, also testing. Late presentation is higher in these groups. And, well, we do not have a big understanding about continua of care among these groups. And also we know that access to treatment for some across Europe is not equal. I'm talking here about free HIV treatment. And I would like to share here a study that looked at 10 European countries, at the situation in 10 European countries, and through the testing services that were done through community-based organizations, more than 2,000 migrants were offered HIV test. You see that the positivity rate was quite high, and more than 30% did not have legal residency. What happened was that more than 50% of reactive cases were not linked to HIV care in the country of their residence, and also the access to fully legal access to healthcare services and insurance was a big issue. And perceived primary barriers by migrants on healthcare access were stigma and discrimination, racism, and language barriers. And societal and community barriers were being able to access healthcare, and sometimes only emergency care was a possible option for those people, and legal restrictions and legal barriers. And within this context, I talked to prepare for this presentation. I talked to two groups of migrants. One group who live in the UK, and one group that lives in the Netherlands. So in the UK, through Africa Advocacy Foundation, so we had a small focus group to talk about their current challenges, because I also wanted to learn a little bit more what are the current challenges related to communication in both countries. So what they were talking about was that we need to understand that the way culture tells stories is different. So the way how we tell the story might be much more straightforward, while the other culture maybe tells the story which is a cycle, or maybe there is the story is told from different angles to get to the understanding. Having a possibility for a private communication was mentioned as a challenge, and also what we talked about, receiving information and services at one place, and also connection. What we talked also about, the ping-ponging between different specialists, and who to connect with, and who to talk about my health challenges. And also, who from this specialist, either GP or HIV consultant or other, who is the person to give the biggest information, and who is the person who manages this information and will support the person along the way. Emergency care was seen again as the quickest way to receive care. And then connection between services and delivery of medication to an address, it was also mentioned as a challenge. And people were sharing stories about switching the medications, and really the need to have an informed joint decision making about this. And the story was actually, it was a person who was communicating with the healthcare provider via telemedicine, And she received an information that today your medications are switched, and let's continue. So what was really important in the discussion was really the understanding a reason to switch, but also giving a space for a joint co-decision making, co-creation, because this will help with motivation and continuation of treatment. Other things that were mentioned. Need to receive information about information in treatment, and many people actually were really thankful for the spaces, for peer spaces, which we talked about, that they were the only spaces that provide information about innovation in treatment and different possibilities. And also the need for skills within the community, the need for skills to frame the appointment with the provider were mentioned as future skills that are needed. In limited time that the providers have, also using digital way of communication, some people were saying that they do not say all the things that they want to say. They limit the information to the minimal information, and somehow the digital form limits this, and then really the short time for the communication. And again, understandable language was mentioned. Need for community peer experts, need for EU, E equals U. E equals U was named as the best kept secret within the HIV sector. And again, peer groups to gain information. And additional information that was coming from the Netherlands, and this was through the process also of developing information to the patients. And it's again the how different cultures weave the story. For a majority of the clients with migrant backgrounds, written information in the leaflet was really not enough, and they would prefer more visual information, as it is related to the visual and oral traditions of storytelling in some countries. And again, language of communication was mentioned, and this group uses positive brothers and positive sisters as the navigators within the healthcare who are working with the network of hospitals across the Netherlands. So also how to start for the newly diagnosed person and a person who starts treatment in the Netherlands, barriers related to start to work, disclosure of diagnosis, but also perceptions about HIV really influence the interactions. And we talked about menopause, and we need to do better. What is the information about menopause? And information about menopause needs to happen before menopause starts. And thank you, Susan, also for mentioning this. And I think we all use patient-reported outcomes, but maybe because there's a lot of information to be shared, maybe there's a need to think how to better use patient-reported outcomes in the communication related to depression, adherence, substance use, and other risks. And I wanted to finish about. We will be talking more about aging and frailty. And we need to talk to clients about polypharmacy, sarcopenia, loneliness, quality of life and improvement. But also we need to teach or self-teach, because this is again the power of peers and how we organize ourselves. I think we do underestimate the possibilities of self-care, how this can help us, but also self-healing. And what I mean by that is about how I take care about myself, how I can reduce my high blood pressure, and here there were some examples about this, how I can support my mental health, and there are a lot of techniques, a lot of technologies that can be used. for self-care and self-support. And to end, I would like to end with the word intention. I think it's this is the most part in the communication, the intention, the emotion, the language, and I think it also comes to self-care of a healthcare provider, because when healthcare provider is not a good balanced state, it's really difficult to do this and detach from all this. From all the stress that is happening, from all the tasks and the multiplication of tasks that you need to do. So self-care, self-care, self-care. Thank you.